Let's start with a snapshot. Sub-Saharan Africa, SSA, is home to 1.1 billion people, and over 60% are under 25. That's a lot of young bodies, dreams, and decisions. But here's the reality. SRHR outcomes vary wildly. A girl in urban Nairobi might access contraception at a youth-friendly clinic. Her cousin in rural South Sudan? She might walk 30 kilometers and still be turned away. Why the gap? Culture, governance, resources, history. Yet there's a silver lining. Africa's diversity is also its laboratory. From Rwanda's community health model to Kenya's digital health apps, SSA is teaching the world how to innovate under pressure. Today, we'll walk through the data, the disease burdens, the demographics, and the quiet revolutions happening in clinics, classrooms, and parliaments. So, what makes SRHR and SSA unique? It's not just about numbers, it's about context. Cultural diversity. In some communities, a girl's first period is celebrated with a ceremony. In others, it's taboo to even say the word. Governance gaps. A country like Botswana has near-universal HIV treatment. Neighboring Zimbabwe? Stockouts of ARVs are common. Regional learning. When Uganda rolled out self-injection contraceptives, Tanzania watched, learned, and scaled it nationwide within 2 years. SSA isn't a monolith. It's a mosaic of challenges and solutions, and that's where the hope lies. Let's talk youth, because they're the heartbeat of this story. SSA has the world's youngest population. 40% aged 0 to 14, 20% aged 15 to 24. That's 250 million adolescents. And with youth comes demand. For contraception, to delay parenthood. For education, to build futures. For safety, from violence, STIs, early marriage. But here's the tension. Systems aren't keeping up. Take Amina, a 17-year-old in Dakar. She wants to finish school. But her local clinic only opens 9 to 5 when she's in class. And the nurse lectures her about waiting until marriage. Policy implication: we need youth-friendly services. Not just in theory, in practice. Let's zoom into the disease burden. HIV/AIDS remains the public health emergency of our time in SSA. 70% of global HIV cases are here. STIs, 357 million new cases annually, many curable, few treated. Maternal deaths? Still 200,000 plus per year, most preventable. But look closer. Adolescent HIV disproportionately hits girls, 3-1 versus boys. South Africa alone accounts for 1 in 3 new adolescent infections in SSA. Why? Gender norms, poverty, lack of negotiation power. A 16-year-old girl in Lesotho told researchers, "He said he'd leave me if I asked for a condom." That's not just a personal story, it's a public health crisis. So let's connect the dots. HIV dominates SRHR and SSA. It's the leading cause of death among women of reproductive age. It fuels maternal mortality. It intersects with gender, poverty, stigma. But here's a success story. Eswatini, formerly Swaziland. In 2011, HIV prevalence among pregnant women, 39%. By 2023, down to 27%. How? Universal test and treat male circumcision campaigns. Youth-led peer education. Think, TikTok videos on PrEP. Progress is possible, but it takes political will, funding, and courage. Let's talk treatment access. In 2016, Botswana, 83% of people with HIV on ARVs. Rwanda, 80%. Zimbabwe, 75%. But Angola, just 23%. HIV prevalence tells a similar story. Eswatini, 27%, South Africa, 19%, Rwanda, 3%. What separates the leaders from the laggards? Leadership. Rwanda made HIV a national priority. Community systems. Botswana trained grandmothers to support adherence. Data. Countries that know their epidemic respond better. HIV doesn't hit everyone equally. Women. 58% of people living with HIV and SSA. 2x infection rate versus boys. Youth face disproportionate burden, especially in high prevalence zones. Why? Biology. Higher transmission risk. Power dynamics. Can't negotiate condoms. Economic dependence. Transactional sex. But change is coming. In Malawi, a program called Dreams gave girls cash transfers, life skills training. Access to PrEP result? 40% drop in new infections among participants. Fertility decline. 1950s. 6.5 children per woman. 2005-10. Chukch 5.1 DRC and 8. Niger. Still 7+. Neonatal mortality. 1990, 43.6 per 1,000 live births. 2016, 27.2. Progress. But regional gaps remain. Urban versus rural. Rich versus poor. A baby born in Sierra Leone is 30x more likely to die before age 5 than one in Sweden. Why the decline? Education, girls in school, later marriage. Contraception, more access, more choice. Health systems, better trained midwives. The SDGs are smarter, but only if SSA is prioritized. WHO estimate 274.371 billion a year needed for SDG 3 in low-middle-income countries. Projected funding gap 54 billion a year. Health workers needed 23 million more, including 3 million doctors. Health facilities 419,000 primary care centers short. But let's flip it. Rwanda trained 45,000 community health workers, one per village. Ghana used drones to deliver blood to rural clinics. Innovation money sometimes. Challenges, progress and prospects. So where are we? Challenges, social determinants, early marriage, FGM, gender-based violence. Autonomy. Only 57% of women aged 15-49 in 51 countries can make their own SRH decisions. Health system fragility. One Ebola outbreak can collapse a decade of gains. Progress. Youth movements. From My Body, My Choice in Nigeria, to condom emojis in Kenya's sex ed curriculum. Policy shifts. Togo just raised the age of marriage to 18. Digital health. Apps like Ask Nivi give anonymous SRH advice in local languages. Prospects. The demographic dividend, if we invest in youth. Regional integration, SADC, ECOWAS sharing best practices, global solidarity, but only if SSA leads the narrative. SRHR and SSA isn't just data. It's Amina choosing her future, Thabo accessing PrEP, Mama Fatima delivering babies safely. You're not just learning facts. You're learning how systems fail and how people rebuild them.